to Chulalongkorn Advanced Respiratory Symposium. My name is Naprika Kong Pun Prom, and today is a great honor for me to introduce our special guest speaker, Professor Marcelo Amado. Professor Amado is from the University of Sao Paulo, Faculty of Medicine Clinics Hospital, Pulmonary Department, Respiratory Intensive Care Unit. He pursued his medical studies at the Federal University of Minas Gerais School of Medicine, Sao Paulo in 1985. After graduation, he presented a doctoral dissertation and successfully completed his post-graduation. In 1996, he spent 4 months in Minneapolis working with Professor John Marney on a project about pleural pressure measurements during acute lung injury and partial liquid ventilation. In 2008, he obtained his professorship from the University of Sao Paulo Pulmonary Department. Professor Amado is an expert in lung protective strategies, and he has published numerous clinical literatures in pulmonary care across many high-impact journals. And today, he will be speaking on the topic of ventilator-induced lung injury and lung protective strategies. Please welcome Professor Amado.
Oh, hello, everybody. Good afternoon. So I'm going to talk about ventilator-induced lung injury and with a special emphasis on COVID patients. As you know, in South America, we are living a hard time, and most of our ICUs are occupied by COVID, and COVID has some peculiarities, but it's still a prototype of ARDS. And so I believe that more than ever before, the topic is a hot topic. So I may have some small conflicts of interest related to EIT because I'm going to show you some examples, not any more than this. So the main clinical findings of COVID are presented in this slide. So it's a patient with severe hypoxemia. It's a little bit disproportional. Typically, the patients don't have problems with PCO2 until the second week of mechanical ventilation. So they start with quite good compliance, usually in the range of 40s. I will come back to this topic because this is very debatable. It's a prolonged course, so we are used to a typical 10 days of a patient with ARDS, but COVID patients, you have to think about 20 days in average. Secondary infection is frequent, also a little bit debatable. Thromboemboli, this is very important, cardiac failure and hyperinflammation. So I'm putting here some question marks in the topics in which there is some new information telling us that the whole subject is a little bit more complicated. The general strategy for these patients is that you have to think about a long-term general anesthesia. And I'm talking about this because this patient is going to stay in the bed for 3 weeks, and we have very peculiar problems related to this. One of the problems is decubitus atelectasis, and we have always to think about this because this is a very important problem and can make your situation worse later on during the course of the disease. This is typically what you see at the bedside. On the x-axis we have days, so 3 first week, then you are on the second week and after the second week of mechanical ventilation. And you typically see this. You start with a patient with almost normal in terms of ARDS. because these values should be around 60 to 80 for a normal patient under anesthesia. But then along the days, you see this deterioration of compliance, which makes your life very difficult if you want to pursue a lung protective strategy. And typically what you see on the CT is something like this. You see ground glass opacities, typical of COVID, but you see also very heavy consolidations in the dorsal parts of the lung, and this is typically decubitus atelectasis. And if you are using EIT, you are going to see a predominantly ventral ventilation. You see very little ventilation, for instance, in this right lung, in dorsal parts of the lung. So typically you see, for instance, 70% ventilation going to the ventral parts of the lung, and only 20 to 30% of the ventilation going to the dorsal. So in our understanding today, this is a signal that your strategy is not well planned. So the general strategy for this, and we are doing a prospective protocol for this, and I'm going to present you some preliminary results. So you have to use PEEP to avoid at the same time collapse and hyperdistension. Ideally, you should titrate PEEP with electrical impedance tomography. You should avoid high driving pressures all over along the mechanical ventilation. And you should use lots of prone positioning in these patients, especially because it's a very effective way of recruiting dorsal tissues. But basically, we have always to individualize. Being a little bit more specific, we should keep protecting the lung during the whole disease. You have to maintain also the trophism of respiratory muscles, so some degree of assisted ventilation is going to be very important, but not too much. And then to do this, you should avoid at the same time too low or too high muscle pressure. Let's talk a little bit about this because this is a very important topic. But again, everything points out to the idea that we should individualize our care. In this recent paper published in the Blue Journal this year, many investigators, I include myself here, we came to this topic of lung and diaphragmatic protective ventilation. What this is telling us. In this paper, we are trying to make the important point that all the experimental evidence we have today is telling us that at the same time that you have to think about your lung, you have to think about your diaphragm, and you have to combine sometimes some conflicting targets to achieve a better outcome to your patients. And this is not easy at the bedside, and it requires a lot of background and theoretical knowledge of physicians. I'm not going over to this busy slide, but the key points is that at the same time you have to protect the lung, you have also to keep some activity on the diaphragm during the course of the disease. And I'm going to give you some examples. So in this protocol, which we have enrolled already 40 patients with COVID, we are testing this strategy against the standard of care of the ARTSNet, in which you are just trying to wean the patient as soon as possible and trying to avoid muscle paralysis, and we are trying to avoid high tidal volumes and high plateau pressure. I consider this as the standard of care. But in this arm, we are also trying to all the time think about lung and diaphragmatic protection, and especially thinking about controlling driving pressure during the patient's stay. To achieve these goals, We don't have to use too much different PEEP. When we titrate PEEP according to electrical impedance tomography, for instance, our average PEEP is 14 centimeters of water, which is not too high. And in fact, the average PEEP in the conventional approach is 12, so it's not so much higher. But if you look at the PEEP levels in the EIT arm after randomization or using the conventional PEEP FiO2 table, you see that in many patients you have to increase PEEP. In some patients you have to decrease PEEP. So the key word here is to individualize. And what we are trying to do when we titrate PEEP according to EIT, we are trying to avoid at the same time collapse and overdistension. So we are trying to avoid, for instance, too high PEEP set by oxygenation in patients that don't need it because they have excessive overdistension. So for instance, this patient 14, we had to decrease the PEEP down to 8 because he was presenting too much overdistension. In opposition, this patient was presenting too much collapse despite the good oxygenation, and we had to increase PEEP. And then we try to minimize driving pressure during controlled ventilation and also during assisted ventilation. So how to avoid high driving pressure during assisted ventilation? Because basically what is going on is that your muscle is doing excessive effort. And you have all the time to think about, okay, is this effort appropriate or inappropriate? Because these patients can have a very high respiratory drive because of sedation and disease. And then you have to somehow calm down this respiratory drive or the effective force of the patient promoted by the respiratory muscles. So in our protocol, we try to use some tricks described in this paper I just mentioned in the Blue Journal to calm down the respiratory drive of the patient that is doing too strong effort. For instance, you have all the time to think that your total driving pressure is the sum of what you set on the ventilator plus what the strength or of the contraction of the muscles, so the driving force promoted by the respiratory muscles. And for instance, in some patients, we have to decrease pressure support levels to CPAP, so zero pressure support, because the force, the contraction of the muscles is so strong that the driving pressure and the tidal volume of the patient is already very high, even if you are using low levels of pressure support. And then in those patients, if you add on top of his high drive a pressure support of 10, you are just going to increase his driving pressure to dangerous limits. We try to have a pH above 7.35 because this decrease a lot the respiratory drive. Sometimes, even if the PEEP level is sufficient to avoid collapse, in some patients a little bit higher PEEP by increasing end expiratory lung volume and activating the Herring-Breuer reflex, this can calm down some patients. And believe it or not, there is a recent paper from Martin Tobin just explaining that in some patients, just increasing a little bit the arterial saturation is going to calm down the respiratory drive. And you can assess this by using P.1. And finally, when nothing of the above works, you can use a little bit of propofol, which is one of the best drugs for this, because it decreases at the same time the respiratory rate and the strength of the muscle contraction. And obviously, you can always paralyze again. And in many patients, we had to step back during the disease 3 or 4 times, paralyzing the patient again to calm down the respiratory effort, and then starting again when the patient was less inflamed. So these are the details I'm not going over, but I just want to mention that after applying this strategy to these 20 patients in each arm, we could observe something like this. We saw an increase in compliance along the first 3 days, whereas in the control group, we see that compliance is stable or deteriorating. So which is the meaning of this? Compliance, you can understand as a kind of a basic property of the lung that does not change in a few minutes. It's an intrinsic characteristic, is reflecting the elastic forces of the lung and how is the basic structure of the lung parenchyma. And when you see a consistent increase in compliance like this, it means that you're improving the lung condition somehow. I'm very confident about these results because when we first applied lung protective strategies 25 years ago in 95, before the publications of the ARDSNet, this is the first graph in which I capture the first signal that lung protective strategies, they are saving lives in patients. You can see here that whenever we apply the low tidal volume to patients with ARDS, we could see not an immediate effect, but a delayed effect that after 3 or 4 days was very strong. Whereas in the control group, we could see that the lung stayed in the same condition along the days or even deteriorating. So when you see an improvement in lung compliance consistent and steady along the days, this is a signal that somehow you are achieving lung protection. And then in this particular situation in COVID patients, all patients are receiving the standard of care of lung protection. So all patients here, they keep a low tidal volume, they keep relatively low levels of plateau pressure, but the only thing we are doing here is to do an extra protection because we are avoiding high driving pressures during spontaneous ventilation and during controlled ventilation, and we are also trying to individualize the use of PEEP to avoid decubitus atelectasis, and then we are preserving, let's say, a reasonable number of lung units to cope with this long journey during mechanical ventilation. And then finally, this is a preliminary analysis because this study is still going on. We should finish, I hope, at the end of the pandemic. But we can clearly see that at the end, this improvement in compliance is also being reflected by an increased number of patients getting rid of oxygen and getting extubated. And I don't have still a significant result because this is just a preliminary analysis, but the results are very encouraging. Okay, so let's go a little bit deeper on how we achieve these goals. First of all, I think some physicians, they are still reluctant in using new technologies. And I think this is a kind of habit which we should change. I strongly believe that we need better tools, and we have to understand a little bit better and monitor a little bit better what is going on with our patients. One of the tools, and here I'm going to mention two important tools that we have at the bedside. We have now mechanical ventilators that they can give us a lot of information, much more than what we are used to collect. And for instance, mechanical ventilators now, they can do expiratory pulse, inspiratory pulse, they can measure P.1, and this, you have to use this to understand if your patient is doing a too strong effort, that you should calm down. And the second thing that is getting more and more common at the bedside is the use of electrical impedance tomography. And I particularly like this technology because you can test different PEEP levels in your patient, like here. So I'm changing PEEP 2 by 2 centimeters of water. And then you can clearly see that when I'm decreasing PEEP here, my lung collapse is increasing at the same time that my lung overdistension in blue is decreasing, And then, for instance, approximately at 15 centimeters of water of PEEP or 14, I have a very good compromise in which I don't see too much collapse, so my PO2 is going to be okay. I don't see too much overdistension, so my PCO2 is going to be okay. And I have a very good compromise to use the PEEP level at this point and collecting the highest possible compliance in this patient and then a low driving pressure. So this crossing point, sometimes it coincides with the best compliance, sometimes not. But this gives you a very important, this finding is assuring you that you should try to set your PEEP levels, let's say, around these values, because you're going to get the best compromise for this patient. And this is very important because, for instance, in this particular patient, using a PEEP FiO2 table that is promoted by the ArtsNet, even using the low PEEP FiO2 table, this patient was very hypoxemic, as it's very common in patients with COVID. And then we set PEEP levels at 18 because we are following the table, because FiO2 in this patient was already at 80%. And then, as you can see, we had a very strong hyperdistension in this patient. Compliance was very low. And then later on, we used the EIT, and we could easily check that just a decrease in PEEP to 15 centimeters of water without a big change in oxygenation. So we didn't see a clear signal in oxygenation at first. But then there was a tremendous reduction in hyperdistension, a little bit increase in collapse. And here in green, I can see the difference between these two images, telling me that most of the lung improved compliance when I did it. And as a result, my compliance almost increased by 50%, which is a lot. In COVID patients, this increment in compliance from 25 to 34, it's a lot. It's a kind of gift that you get at this point, and reserve that you get at this point to apply protective ventilation along these 3 weeks of mechanical ventilation. Not to say about blood gases, because typically oxygenation does not improve immediately, but along 2 or 3 days, you are going to see a progressive improvement in oxygenation when you optimize your driving pressure and lung mechanics. And then I have many examples. In some patients, I have to increase my PEEP level, big improvement in regional compliance. All these green regions, they improve the compliance. You can see that using this conventional or traditional PEEP in this patient, I was missing ventilation in the left lung, and you cannot assess this with your clinical examination. And then again, I had almost double compliance in this particular patient. Also interesting is that when I first do an evaluation of a patient in supine and then in prone, you can be surprised by some findings like this. For instance, in this particular patient, the ideal PEEP in supine was 14, but in prone position was higher. And we have seen also the opposite situation, in which in prone position you need less PEEP, much less. So you have to individualize your strategy by patient and by positioning. And also by positioning, you should also think about an elevated head or turning the patient side by side, because everything can change your lung mechanics, and you should continuously evaluate what is going on with the patient. Before going on, I would like to step back to talk about this topic. Because when I'm talking about collapse reduction, some people immediately have an antibody response and say, wow, if you are increasing PEEP and trying to decrease collapse, you are trying to tell me that the open lung approach is a good strategy. And then, as you may know, some recent trials on mechanical ventilation, they seem to contradict this principle. My point during this presentation is that the rationale and the physiology of the open lung is still alive and consistent. The problem is that we have some methodological problems in some recent trials on mechanical ventilation that they cause the results of the clinical trials very confusing. And let me explain a little bit better this point. So I really think that in the recent trials we have problems, methodological problems with feeble efficacy, with patient selection, and poor management of hemodynamic problems, for instance, renal failure, because if you are applying a little bit higher PEEP and you are trying to avoid lung collapse, you have to get a different strategy for managing the hemodynamic system. And then something very important that we are going to discuss in this presentation very briefly, but a little bit better in the next presentation, is that it's very clear that we have much more desynchrony problems than we thought in the past. And also something absolutely new, that if your patient is doing spontaneous effort, it's very common to have excessive expiratory muscle effort. And we did not know about this a few years ago, and this is impairing a lot the outcome of patients. So briefly, where we are. So we have 3 big negative randomized clinical trials. In all these patients, we had a fair amount of patients, so big numbers. All the patients, they have the same entry criteria, and all the trials were testing some PEEP strategy against the low PEEP ARDSMET strategy. So if all these studies are negative, why I'm telling you that in COVID patients, we are still testing a strategy like this? And not only this, if you think about the ART trial, it's not only neutral. We had significant worse results. And the background of these 3 negative trials, we also have other negative trials that were tested in 2009, the alveoli, the LOVES, and the EXPRESS. In all these trials, we did not see a protective effect of PEEP. And we may think that the overall scenario is very depressive. So every time we try to test if optimum PEEP strategy, or let's say a standard high PEEP is good, we always fail. So what is going on, and why I believe that we have now a very good chance of showing a beneficial effect? This blue line is the low PEEP FiO2 table of the ARDSNet. This is the PEEP level, and this is FiO2. And this is the high PEEP FiO2 table. And so if physicians are following the guidelines, they should choose PEEP levels along these two lines. But what we see around the world is this. So physicians are not even using the low PEEP FiO2 table. So they are using even lower PEEP than, let's say, suggested by those tables. So I think this is related to this depressive mood that physicians don't believe any longer that PEEP could be helpful. However, you should think a little bit about this and make a more careful judgment. Why? Because if you look at the literature, we have this very nice publication in 2017, randomized trial, and we are testing in 320 patients moderate to high PEEP strategy against the conventional PEEP strategy. And this study was carefully performed in one single institution, but with a big number of patients. And we could see a remarkable recruitment in the patients. And then when we achieved this result, we had a higher number of patients discharged from the hospital, which was significant, a higher number of patients discharged from the ICU, and something that I think it was very important, we had a lower number of patients needing oxygen after extubation. In animal studies, when we are successful in promoting a lower driving pressure by applying the right amount of PEEP, we can for sure achieve lung protection as shown in these slides, despite the fact that I'm using exactly the same tidal volume and the same, let's say, maximum pressures applied in those patients, but particularly in those patients, by applying the right amount of PEEP, we could avoid the ventilator-induced lung injury because we achieved a lower driving pressure. And then we could show that there was less inflammation, there was less fibrosis, less collagen production. The PET studies were remarkable, showing much less inflammation. Inflammation appears as yellow colors. So in the patients in which we could apply appropriate levels of PEEP, we could decrease inflammation. And this was not only our group. These other investigators from Germany, they also showed much less inflammation when applying high PEEP in the context of a little bit of spontaneous effort. Finally, if you look at these patients in Boston, super obese patients in Boston, and this is a recent paper from the Critical Care Journal, and you look at the mortality when they are applying the conventional PEEP or they are applying the open lung PEEP titrated by electrical impedance tomography or esophageal balloon, you have a remarkable result, half the mortality. And this is my last argument here, that and my last evidence that we should pursue this target. If you look at the alveoli study published by the ARDSNet, and which is, as you may know, this was a negative study. But if you look at patients with high body mass index, they had much lower mortality when they received high PEEP strategies. So my conclusion is that the rationale is still valid. All mammal species, they suffer from ventilator-induced lung injury, but it's getting very hard to show the results in randomized trials. And the reasons for this failure are pointed out by my previous slides. So it's related to methodological problems. And is this an insolvable problem? Has this problem of methodological errors happened before? Let's take a look in the story of protective ventilation. This is what was happening in the years 95 to 2000, when we first published a study, a small study in Brazil, showing that protective strategies were decreasing mortality. If you look what happened in the next years, look at this. 3 other studies in different countries were showing higher mortality when we were decreasing tidal. So a decreasing tidal volume was causing harm. And everyone was telling me that this study was a kind of fallacy or a kind of isolated result by chance. And including some people from my hospital, they started to tell me that our hypothesis was wrong and that we had to start using again high tidal volumes. And then, boom. In the year 2000, I was very happy to see this big publication in the New England Journal where the ArtsNet confirmed these first results that we published in Brazil, that lower tidal volume was decreasing mortality and improving survival in patients. And you see, so even for showing something that was much easier, which was to show that high tidal volume was increasing mortality, took us a long time to show. And why it is? Because every single study had a methodological problem that later on we needed a long time to solve. And some people say that the problem of ventilator-induced lung injury is so difficult to solve like the global warming. And, but if you look very careful to the evidence, it's like, let's say, it's self-evident in some cases that maybe we should take a different approach. And again, I tell you that what we need to improve this approach is to have better technology. And as I told you, we need to check what is happening in the lung. And one of the key tools we have at the bedside is EIT, because we can track the optimum PEEP level, we can track the increasing collapse when you are decreasing your PEEP levels or transpulmonary pressures, and you can also track overdistension. I'm not saying that EIT is the only tool you can have at the bedside. You can use esophageal balloon, you can use other technologies, but you have to be aware about the methodological problems of each technology. And I like to say that the devil is in the details. So every detail that if you are using a new technology, you have to use how to measure it. And this is an important problem. Just a few words now about the ART trial. The ART trial was the only clinical trial in which a high PEEP strategy in some lung recruitment caused an increase in mortality. And in this trial, there was a significant reduction in driving pressure along the first week. However, this reduction was very feeble, very tiny, and it's almost impossible to show a clinical benefit with just 1 centimeter of water drop in driving pressure. And just to show you that we can achieve much better results with new technologies, look at this. This is a paper that we published in 2018, so 2 years ago, anesthesiology. And what we are showing in this paper is that when we use EIT during abdominal surgery, we can apply a certain PEEP level, like in this patient, that we can prevent atelectasis in the post-operative phase. So these patients took a CT in the post-operative phase after extubation. So these blue areas of collapse, they were still remaining in this lung after extubation. And look how impressive is what happened with these patients. So after extubation, all this part in blue was collapsed, even after receiving a session of physiotherapy. And these patients received the conventional PEEP of our institution, which was 4 centimeters of water or 5. And this patient stayed in the operating theater for 4 hours. Now imagine what is going on with a patient with COVID staying in the ICU for 3 weeks. This is exactly what I'm talking about. You have a decubitus atelectasis, and we should try to avoid this. In this particular study, when we did it, we avoid atelectasis. We could decrease the driving pressure by 6 centimeters of water during the whole surgery and after the post-operative phase. Most importantly, in some patients, the reduction in driving pressure was more than 10 centimeters of water. And this is exactly what I'm thinking about when I'm saying that optimizing PEEP could be extremely important for COVID patients. So it's not a question of the phenotype. And we have a recent study published in the Blue Journal showing that even if you take a patient with good compliance or bad compliance, in all patients, you can still optimize your PEEP level if you apply the right technique. And obviously, some patients are more recruitable than others. So, for instance, this animal in the top panel responded very well to a recruiting maneuver, while this animal in the bottom didn't present a big recruitment because he had already an open lung. And it's extremely important to know this when you start to do mechanical ventilation in your patients. And we are developing new tools to achieve this. One of these tools is an automatic system in which you can do certain maneuvers at the bedside, even if you are just increasing your PEEP levels. And at each increment in PEEP, the EIT can give you in this blue column how much of your lung is getting functional when I increase PEEP or do some maneuver at the bedside. And for instance, for this particular patient, I can see that increasing PEEP was very good because I was achieving almost 100% recruitment, and this patient started to have a very functional lung. And on the other hand, in some patients, even when they have a very low compliance, you may get surprised to see that these patients start with 80% of the lung recruited and there is no response to PEEP. So we need these tools at the bedside if you want to apply a good strategy. I'm going to stop here because I would like to tell you that nowadays we are applying this strategy not only during the passive phase of mechanical ventilation, which happens typically in the first 72 hours of these COVID patients, but also during the remaining phase of mechanical ventilation. And in some patients, it's common that we keep the same PEEP levels at the very beginning till the end of the disease, because we realize that the strongest determinant of the PEEP level required by the patient and the PEEP level titrated by EIT is an anatomical factor. So it's much more related to the body mass index of the patient than the disease per se. The disease is a minor contributor. You can change your PEEP level by 2 or 3 centimeters of water, but the anatomy of the patient is the major determinant of the required PEEP level. After setting your PEEP level, you have to somehow use all the tools you have at the bedside to avoid a high driving pressure. So during controlled mechanical ventilation, this is easy because you just set your ventilation at low tidal volume. But during the assisted phase of mechanical ventilation, I have mentioned to you that you have to use all this sequence of steps to avoid a high respiratory drive of the patient and then promoting a protective ventilation. And I really hope that in a few months, we will finally show a successful example of a protective ventilation trial in these COVID patients. Thank you very much.
Thank you very much for your excellent talk. I have some questions. Now we have the papers about the many experts published the way to access the lung recruitability by using the recruitment inflation ratio. What is your opinion about this technique?
Oh, very nice. We are. Let me just stop here. I participated very much in this recruitment to inflation ratio, which was developed by Lu Chen and Laurent Brochard. I like it very much, this approach. And essentially, this approach is using something very similar that we use in EIT. In EIT, EIT is automatically calculating this vertical displacement between PV curves, which is precisely what the recruitment to inflation ratio uses. But in addition to this vertical displacement in lung volume, which is basically a kind of volume gain at the same pressure that you get by using PEEP. EIT is also analyzing a little bit of the compliance in each region of the lung. And then when you compose these two indexes, I think we get an even better index of lung recruitability. So in a multi-centered study that we are doing now, and we are doing this in collaboration with Professor Laurent Brochard, we are using many different centers around the world, each one with a different EIT device. And then we are collecting this data together and also the recruitment to inflation ratio. And then we are comparing both. And then let me tell you more or less what we are observing is that the recruitment inflation ratio is already a good estimate of the recruitability of the patient, but I think we are going to get a better accuracy if we use EIT. But if you don't have EIT, I like this approach because it's already an indication that your patient can benefit from an optimal PEEP strategy. I like it very much.
Okay, and when we observe the COVID-19 patient, we observe that the lung mechanism change every day. And for the PEEP titration, do you use the technique for PEEP titration every day, or just only observe and maintain the same PEEP and decrease just only 2 centimeter waters day by day?
Oh, this is a very good question. In some patients, you start to get some clues that the patient is getting now an excessive PEEP. One of the clues is that you start to see a little bit higher PCO2, And in some patients, you started to see in EIT that you start to see too much dorsal ventilation. And this is, for me, it's a clear signal that, okay, it's time now to test a different PEEP level. And then we typically, if we can, we titrate again. But obviously, if you are too busy, you just go, let's say, empirically to a little bit lower PEEP level. And let me tell you that in some patients, I had also to increase PEEP along the time because the patient had a secondary infection and now has an increased intra-abdominal pressure or something like this. So it's something that we should re-evaluate every day. And I particularly like the daily measurement of two things. First is that I'm always checking lung compliance, and lung compliance should stay the same or increase a little bit every day. If you are stuck or deteriorating, it's time to reevaluate your strategy. And the second point is that, okay, if you have an EIT image, this upper-lower ratio gives you a very quick indication. So if you start to see too ventral ventilation, boom, you can be sure that you have dorsal atelectasis. If you start to see very dorsal ventilation and no ventilation in the apex, it's because your PEEP level is getting excessive.
Okay. And when then some patients have their high drive because the COVID-19 sometimes have a prolonged course, and we cannot decrease the sedation or the neuromuscular blockade agent. And sometimes patients have their lung collapse from the spontaneous effort. And how do you measure this, the effort? Because most of the patients, we don't use the esophageal pressure as a routine use, and we cannot measure the spontaneous activities. What do you recommend to observe or measure this?
I'm very a big fan of what we call the occlusion maneuver. Okay, in some ventilators you can press the expiratory pause button, and you do without the perception of the patient, so the patient don't realize that you are going to do the maneuver, and then he does a strong effort as in the previous breaths. And then this occlusion maneuver is very well described by a researcher called Ewan Golliger and Bertoni. And then what they show is that even because everyone had in mind that P.1 was a good index because the brain does not recognize the obstruction. And when you do this whole occlusion, there is some reaction of the brain. But the interesting finding of Ewan Golliger is that you can, after doing this maneuver to thousands of patients, and I have done the same, you can more or less assume that during the occlusion, your strength is going to be 25 higher than in the previous non-occluded breaths. So if you, let's say, if you measure an occlusion pressure of 10, so for example, the patient is at a PEEP of 10, and then boom, goes down to 0, and then return to 10. If your occlusion pressure is 10, your muscle pressure is 7.5, so 25% less. Okay, and this index is very good to estimate more or less how much pressure the patient is doing. For instance, in some ventilators that they don't have this expiratory pause, now they have this negative inspiratory NIF maneuver, like if you are trying to do you are trying to measure if your diaphragm has the strength to the weaning phase. So in every ventilator you can find a way of doing this occlusion maneuver, which I find very interesting because it's one of the best. And one good thing that Ewan Golliger also showed is that the reliability of this index is as good as an esophageal pressure catheter. So you can use it very, very well.
Okay, and thank you very much because of the time constraint. On behalf of the Primary and Critical Care Division, Department of Medicine, Faculty of Medicine, Chulalongkorn University, we would like to thank Professor Amato for the great presentation. Thank you very much.
My pleasure. I really hope that you have a nice evening and afternoon.
Thank you very much.